For millions of people, chronic bladder pain is just a daily reality. It's this frustrating, often invisible condition that can totally take over your life. And for a long, long time, it's been one of medicine's biggest puzzles. So today, we're going to piece that puzzle together and bring some much-needed clarity. Okay, let's dive in. So let's just start with a question that honestly changes everything. For more than 100 years, we've been hunting for one cause and one cure for something called interstitial cystitis. But what if the reason it's been so impossible to solve is that we've been asking the completely wrong question this whole time?
And that brings us to this really simple but really powerful idea from way back. How we define a problem, especially a medical one, shapes everything that comes next. How we diagnose it, how we research it, and most importantly, how we treat it. To solve this puzzle, we have to start with the basics, getting the words right.
Okay, so here's the modern definition from the American Urological Association, and the wording here is so important. Notice it says unpleasant sensation. That could be pain, pressure, discomfort. It's all about the symptoms. It starts with what the patient is actually experiencing, not with some lab test. And maybe most importantly, this label is only used after a doctor has ruled out all the other obvious stuff.
This timeline really explains why there's been so much confusion. It all started way back in 1876 with a name that assumed there was specific inflammation. Then, in 1918, a doctor found these things called Hunter lesions, but only in a small group of patients. But here's where things really went off the rails. In 1987, a super strict definition was created just for research. It was so narrow, it actually kicked out 60% of the people who had the condition. It led to decades of frustration for patients and doctors, until we finally got to where we are today with this much broader, more inclusive umbrella term IC/BPS.
So just how many people are we actually talking about here? Well, the numbers, they're pretty staggering, and they really show why getting this right is so important.
Get this. Based on a huge landmark study, as many as 7.9 million women in the United States have symptoms that fit this description. To give you some perspective, that's more than the entire population of the state of Arizona. This is not some rare, obscure condition.
And let's be clear, this is absolutely not just a women's health issue. The same study found that up to 4.6 million men are dealing with these symptoms too. And honestly, that number is probably way too low because in men, it's so often misdiagnosed as something totally different, like chronic prostatitis.
So here's a crucial point to understand. A doctor can't just run a single test and say, yep, you have IC/BPS. It's what we call a diagnosis of exclusion. That means your doctor basically has to become a medical detective, carefully ruling out a whole list of other things that could be causing your symptoms first.
And just look at how complicated that detective work can be. I mean, the symptoms could be coming from the bladder, for sure, but they could also be from something gynecological like endometriosis, or a GI issue like IBS, or even from the muscles of the pelvic floor itself. A doctor has to think about and rule out all of these other possibilities before they can land on a diagnosis of IC/BPS.
This right here, this is a profoundly important statement. I can't tell you how many patients have gone through invasive tests, like a bladder biopsy, only to be told, well, everything looks normal. This is validation. It means your pain is real, even if the tests don't show an obvious problem. A normal test absolutely does not mean it's all in your head.
Which brings us right back to our big question. If it's a diagnosis of exclusion and tests can come back normal, and it affects millions of people in so many different ways, then what are we actually dealing with here? Well, the answer is the breakthrough that has changed everything.
Here's the breakthrough. It's not one thing. It's a heterogeneous syndrome. The best way to think about it is like an umbrella. IC/BPS is the name of the umbrella, not the name of the rain. It's a term that covers a bunch of different underlying problems that all happen to look similar on the surface.
So, the first big step was to split that big umbrella into two main categories. On one side, you have true interstitial cystitis, or IC. This is an actual inflammatory disease where a doctor can look inside the bladder with a camera and see these very specific sores called Hunter lesions. But, and this is the key, that's only a small minority of patients. The vast majority fall under bladder pain syndrome, or BPS, where the bladder itself often looks totally normal, even though the pain is just as bad. So, how do we make sense of that huge group of people with BPS? Well, the modern approach is a total revolution in thinking, and it's called phenotyping. It's all about looking past the single diagnosis and instead identifying a patient's specific profile, their phenotype, to figure out what's really causing their pain.
And what researchers have found is that there are several of these major phenotypes. So we've got the Hunter lesion type we just talked about, that's about 20% of patients. But now look at this. Pelvic floor dysfunction is a factor in a whopping 80% of patients, and more than a third of them have a widespread pain profile. And what's absolutely crucial to understand is that these aren't mutually exclusive. A single patient can have more than one phenotype at the same time.
Let's quickly break these down. First, the Hunter lesion phenotype. This is the classic form we've known about the longest. It's a true disease of the bladder wall itself, where you can actually see the inflammation. The big clue is finding those red patches when a doctor looks inside the bladder with a camera.
Okay, now for the big one, the most common type by far, pelvic floor dysfunction. The key thing here is that the problem might not even be in the bladder. It's in the muscles around the bladder. They get super tight and tender, and they can send pain signals that feel exactly like they're coming from the bladder. And the only way to find this is with a specific, hands-on physical exam.
And finally, there's the widespread pain phenotype. This is when the problem is bigger than just the pelvis, the patient's entire nervous system has become extra sensitive, a state we sometimes call centralized pain. The main clue is when someone also has other chronic pain conditions like fibromyalgia or IBS. For these people, the bladder pain is one piece of a much bigger puzzle. And this is where all the pieces of the puzzle finally click into place. Understanding these different phenotypes isn't just an interesting academic exercise. It completely changes the game when it comes to treatment. It creates a whole new, much more hopeful path forward.
Just look at how beautifully this all maps out. Instead of just throwing random treatments at the problem and hoping something sticks, we can now match the therapy to the specific phenotype. If you have Hunter lesions, the treatment goes right to those lesions. If the pelvic floor is the main driver, specialized physical therapy is the answer. And if it's widespread pain, you need treatments that work on the whole central nervous system. It's logical, it's targeted, and it works so much better.
So, let's boil this all down into a clear path forward for you. Number 1, start thinking of IC/BPS as a syndrome, not a single disease. 2, never ever let a normal test make you think your pain isn't real. 3, the whole goal now is to work with your doctor to figure out your specific phenotype or a combination of them. And 4, use that knowledge to advocate for treatments that are actually aimed at your specific problem.
Really, this is the bottom line. For decades, the approach was trying to shove every patient into the same box, and it was just frustrating and ineffective. We are now finally moving into an era of precision medicine for bladder pain, where your unique profile gets a personalized solution. And that is a huge reason for real hope.
And that leaves us with one last thought. This massive shift in thinking, from one disease to many phenotypes, has totally unlocked the bladder pain puzzle. It really makes you wonder, doesn't it? What other complex conditions, like chronic fatigue or IBS, could also be hiding a bunch of different problems under a single name, just waiting for us to start asking the right questions?